My name is Mahala Harrell. This is my microbiology case study for MLS 461. Patient history, we have an 18-year-old male presenting. He's got no significant history of disease. He's got a persistent cough for 2 to 3 months with hemoptosis, which is blood production in the cough. He has fever, night sweats, and unintentional weight loss of 15 pounds. Patient denies any previous smoking or vaping. The patient's grandmother was previously diagnosed with pulmonary tuberculosis, but at the time of her diagnosis, the patient's interferon gamma release assay was negative. And since then, he has had extensive travel to both Europe and Asia. Preliminary thoughts: physician suspected pneumonia and admitted patient. Basic blood work was unremarkable. The physician then ordered a CT and chest CT and X-ray, along with bronchoalveolar lavage fluid, sputum, and blood to be cultured for bacterial, fungal, and mycobacterial organisms. The CT scans revealed a 4-centimeter lesion in the lower right lobe, which you can see here and here on the scans, which we know to be tubercle, a negative fungal culture, and the patient was HIV negative. The sputum smear revealed 4+ acid-fast bacteria in the aramine rhodamine stain. Acid-fast bacteria cannot be stained in the gram stain, as they have high lipid content in the cell wall that prevents them from absorbing that stain. The patient's quantiferon TB gold test is now positive, which is the same as the interferon gamma release assay. Mycobacterium tuberculosis is confirmed by a laboratory-developed TB PCR as well as a commercially developed TB PCR assay. And the specimen was also sent to the CDC for DNA sequencing to predict antibiotic susceptibilities. Treatment for this patient. The CDC DNA sequencing revealed a drug-susceptible tuberculosis, which is really good. So then the patient was then started on first-line anti-tuberculosis drugs. Doctors here prescribed ethambutol, isoniazid, pyrazinamide, and rifampin. The patient was discharged only 4 days after admission with a follow-up to the Department of Health. Mycobacterial sputum culture was completed after 6 weeks. The growth confirmed pan-susceptible Mycobacterium tuberculosis. Okay, so Mycobacterium tuberculosis. Here I have a picture of the colonies on LJ Media, and there's a picture of the organism with an aramine rhodamine stain. I know it's hard to see, I'm sorry. I'll also link the PowerPoint in my submission. But M. tuberculosis is one of the most lethal microorganisms. It is an acid-fast bacteria, so that means it's got the high lipid content in the cell wall, makes it harder to stain. It's got a high incidence area of the world, would be Sub-Saharan Africa and Eastern Europe and Asia, which our patient visited both Europe and Asia, although it did not specify what part of Europe. Then there are 3 forms of tuberculosis. There is primary TB, which is the tubercules form in the lungs from the bacteria multiplying in phagocytes. Extrapulmonary TB, which is when it infects both lungs, which is pulmonary, and the bones, which is Pott's disease. And then miliary TB is disseminated, and there are millet seeds present. So let's move on. Okay, so from our lecture notes, we learned MTB is a slow grower, so it takes greater than 7 days to culture. The culture is also held for 6 weeks. It can be inoculated on Levy Jennings media. which is a solid media, and it contains malachite green to suppress gram-positive growth. There's also a liquid media, which is tween 80, which contains oleic acid. Colonies would appear rough and buff with cording. The rough means cauliflower-like. Here's a close-up of the colony. They are non-chromogens, so Mycobacterium are categorized by photoreactivity. MTB is a non-chromogen, which means it does not produce pigment in or out of light. There are also photochromogens, which produce color with light, and scotochromogens, which produce pigment with or without light. M. tuberculosis is the only non-chromogen, which is nitrate and niacin positive. That is important for identification. Testing would include a purified protein derivative skin test, also known as the Mantoux tuberculin skin test. This is done by inoculating part of the forearm with tuberculin and then reading 48 to 72 hours after. It is positive if there is any sort of inflammation or a hard spot or anything like that. Anything out of the ordinary could be considered a positive. And then there's also the quantiferon TB Gold, which is the interferon gamma release assay, which is a blood test. And it is treated with a 9-month course of antibiotics, which we learned in class as isoniazid, rifampin, streptomycin, and ethambutol. Okay, so our workup. The CDC recommends a nucleic acid amplification test for rapid ID of tuberculosis and DNA sequencing for susceptibility. This is because the culture can take up to 6 weeks to grow. Tuberculosis is a very serious disease, and it needs to be diagnosed as quickly as possible and treated as quickly as possible. Patients should also be put in isolation as quickly as possible to prevent the transmission. This is a negative pressure room with airborne precautions for anyone who has to enter. This is also important, the DNA sequencing to predict antibiotic susceptibility, because there are drug-resistant strains increasing, which is very bad, because this is a very lethal disease, a lethal microorganism. Okay, so our summary is, although it's less common in the US, Mycobacterium tuberculosis is a major global pathogen. The gold standard of diagnosis is culture and sensitivity, but due to the severity of the pathogen, nucleic acid amplification testing and DNA sequencing are recommended to decrease the likelihood of transmission as well as the time taken for adequate treatment. And the CDC even recognizes nucleic acid amplification does have its limitations, and it knows, that the gold standard is culture for a confirmation of this disease. However, the culture takes so long that we need to treat the patient, we need to, diagnose the patient, treat the patient as adequately as possible, as quickly as possible, to give them the greatest chance of survival, to give them the greatest care in general. Here are my works cited. Thank you very much.